Thank you, Dr. Dorsalla, for inviting me. It's a great pleasure and honor, and I appreciate your words, and I really appreciate the great hospitality I always meet in India. So today, I have been asked by Dr. Servanas to prepare this talk, and I think he was right to choose this topic because provocative test in video nystagmography, which is the cornerstone for vestibular testing, they are important, and there are some tips which are not written in the text box and frequently not highlighted in the talks or workshops. So why we do provocative tests? We need the provocative test either to reveal a pathology or to reveal a latent unilateral vestibular dysfunction. All of us are aware that is, if we have a unilateral vestibular hypofunction due to neuritis or due to any other condition, it's physiological compensation will happen, and the spontaneous nystagmus and the many other signs would disappear clinically and even with the video nystagmography. So sometimes only they present like with a very fast head movements, the patient will be symptomatic. So you need some provocation to show if there is a latent vestibular hypofunction. So what kind of provocation methods we use? We use certain positions like the Dixwell-Bayek test. We use gaze changes to see the effect of gaze on nystagmus. We do head shaking. We do some pressure testing. We do sound stimulation and see if it can provoke nystagmus or no. We use vibration. We do hyperventilation. We do caloric stimulation. And lately, it comes to the literature, the magnetic stimulation. And if you don't know, the vestibular system is the organ which sends the magnetism. And actually, one of my Ukrainian friends, Professor Konstantin Turyans, he wrote a book chapter on magnetic stimulation of the vestibular system, maybe more than 10 years ago. But recently, especially the Johns Hopkins group led by Professor David Z, they started doing research on the effect of magnetic stimulation on the vestibular system, and they have some publications. So we'll go through each one of these provocative tests. You cannot do everything for each patient, so we have to tailor. Most of you work in busy clinics, and even you have the time, the patient, we don't have to expose the patient to all the testing. That's exhausting and time consuming and sometimes boring to the patient. So you have to tailor which test you choose or subtest you choose during the video nystagmography based on the clinical history. So if I have a history very suggestive of benign paroxysmal positional vertigo, most of the time I go directly. And I ask him if which side you feel the symptoms more. If you told me the right side, I test usually the symptomatic side first. So always try to go to the point. The sequence also, the clinical history should be considered for the sequence of video nystagmography. And usually we start by looking for spontaneous nystagmus with and without fixation. Why spontaneous nystagmus? Once you found the spontaneous nystagmus, that means vestibular asymmetry. It could be peripheral, it could be central, but you have a very clear sign that there is some sort of vestibular asymmetry. So the first thing we look for is the presence or absence of a spontaneous nystagmus. The second, we look for gaze-evoked nystagmus with and without fixation. And we will talk in details about the gaze testing. Head shaking in nystagmus, because that's easy to perform a test which can reveal any hidden or any latent vestibular asymmetry. Hyperventilation-induced nystagmus, we'll talk in details. Pressure and sound-induced nystagmus. So one of the important points, actually, in video nystagmography is the effect of gaze on the presence or in the degree of nystagmus. All of you heard about Alexander's law, which usually describes the vestibular nystagmus, because looking to the direction or directing the gaze to the direction of the first phase of nystagmus usually provokes or enhances the nystagmus. And looking far away or to the opposite side of the first phase of nystagmus reduces the nystagmus. So keep this in mind because this is very important. There is important clinical point. During all the video nystagmography recording, always try to keep the pupil in the mid position, in the central gaze. Because if the patient is looking to the right, they will have sometimes this end-point physiological nystagmus. The gaze-evoked nystagmus will show. So during the positional testing, or during the caloric testing, during most try always the optimal condition to record accurately is to keep the pupil in the mid position and the gaze to the center. Unless you intentionally want to see the effect of gaze. And I give you a secret, just whenever you have a doubtful nystagmus, you have in a certain position, you have a few beats of weak right beating nystagmus. So what you do to get sure if it's a real nystagmus or what? Simply ask the patient to look to the right. So asking the patient in the same position, just to direct the gaze to the right, that really makes the nystagmus clear. So if you have some, you don't know this is some saccadic oscillations or it's a real nystagmus, just ask the patient to direct the gaze to the direction of the first phase. If it's a true nystagmus, it will become more robust and more clear. So the effective gaze is very important. And the concept should be clear. I made a table and I prepared it specifically for this workshop, just the concept of the gaze-evoked nystagmus. I can see a spontaneous nystagmus. Yes, this spontaneous nystagmus get stronger when I ask my subject or the test subject to look towards the direction of the first phase. This is understood. I might have a less degree of spontaneous nystagmus, which is called first degree. So only in the central position or in the neutral position, the patient doesn't show spontaneous nystagmus. But when he looks to a certain gaze, he got some beats of nystagmus. So the first degree of spontaneous nystagmus, you will see only if the patient directed the gaze in the neutral position towards the direction of the first phase. Then you might see in many different other positions. Let me to ask you, do you have a clear definition of what's called spontaneous nystagmus? And I will follow Dr. Manoj's approach. We need some reaction. Do you have a clear definition for what you can describe as a spontaneous nystagmus? Yes, sir.
Nystagmus which appears without any provocation.
Perfect. But in which positions?
In one line, I would like to put it that way.
Yeah.
We're talking about provocation tests and...
No. I mean, what is the spontaneous nystagmus?
So that comes unprovoked.
That's perfect, but comes where or when?
Without changing the direction of the gaze, without any position change, without anything.
That's correct, but let me to add something. Spontaneous nystagmus is a nystagmus you see in the neutral position. Okay, but still you can have a spontaneous nystagmus which is not in the neutral position with the central gaze. Spontaneous nystagmus called for any nystagmus which you see the same nystagmus with the same direction in more than 5 positions. So in more than 5 positions. Because if you follow the natural history of the vestibular compensation, the spontaneous nystagmus in the neutral and central gaze will disappear first. So the third degree spontaneous nystagmus will become like second degree, then it will become first degree only if looking to the gaze. After some time, in the neutral position, it will disappear. It can just remain like in many different positions. So during the Dixwell bike, during the head right, head left, you can see. But it should be of the same direction in 5 positions. And it should be not changing its direction at all. And should be not changing its direction at all. So this is what we call spontaneous nystagmus. Okay? If it changes its direction in one position, it's not a spontaneous nystagmus. This can occur with the lateral canal cubulocysts or lateral canal apogeotropic forms. You have what's called pseudo-spontaneous nystagmus. So what is the difference between pseudo-spontaneous nystagmus and spontaneous nystagmus? In pseudo-spontaneous nystagmus, you will find one position which the nystagmus disappears or it changes or reverses its direction. But spontaneous nystagmus is a nystagmus which is seen in more than 5 positions, and it doesn't change its direction. Okay. So this is, I made, this is for you to make. So when I look for nystagmus with the gaze, so first, if I have a spontaneous nystagmus, I will see that in the in the central gaze, and I see it in the right, and I see it in the left gaze, but with the same direction. So this is a spontaneous nystagmus. I could see a spontaneous nystagmus in the center, or I could see it continue to be either in the left or the right, but when it, in one of the gaze, it reverses its direction. I know most of all of you know from the books what's called the bronze nystagmus. You know what's bronze nystagmus? Yes, perfect. So what is bronze nystagmus? The patient has in the neutral position a spontaneous nystagmus. Then in one side, he has the same spontaneous nystagmus with low amplitude and more frequency in that gaze. But on the opposite side, he will have the gaze-evoked central cerebellar generated nystagmus. So he has a spontaneous nystagmus in the middle. He has the same spontaneous nystagmus in one of the side, but in the opposite side, the nystagmus, it changes its direction. Okay. Third possibility, which is the gaze-paretic nystagmus, which can occur as a side effect of the medication. It can occur with central disorders, cerebellar disorders, where in the center, no nystagmus. But when you ask the subject to look to the right, they will show a right beating nystagmus. When look to the left, left beating nystagmus. This is due to the integrator deficiency, and this is or what's called gaze-paretic nystagmus. Problem in the central integrator of the gaze. The system is unable to keep the eye fixed in a certain gaze. Okay, so we have 3 possibilities. You have the spontaneous nystagmus, same direction in all the gaze conditions. You have spontaneous nystagmus with superimposed central component with beating in the opposite direction. And you have the gaze-evoked nystagmus or the gaze-paretic nystagmus, nothing in the central gaze, but only when looking to the right or looking to the left. Head-shaking nystagmus. Another test most of you know how to do, and we can show this in the hands-on session. You do head shaking 1 to 2 hertz frequency for 20 times or 30 times. Actually, to be effective, it should be vigorous. But doing a vigorous head shaking is not safe in elderly, not safe with those with like retinal detachment or intraocular lens. Not safe with too much osteoporosis or neck problems. So just choose the patient who can do vigorous head shaking. But to be more sensitive, it should be little vigorous. So what kind of finding we can see with the head shaking? You do the shaking, then you look for nystagmus. So it's either present or absent. So if it's positive, the test, you will see nystagmus. So what are the possibilities of nystagmus? We can see first, you can see a monophasic horizontal nystagmus, which is like a nystagmus beating in right or left direction. So what it does mean? Head shaking is a peripheral or central. If you have post-head shaking nystagmus, is it peripheral or central? Answer. We don't know. It's a non-localizing, non-specific. It means there is vestibular asymmetry. This vestibular asymmetry can be on the peripheral level or can be on the central level. So just having positive post-head shaking doesn't mean anything. It does mean only there is some vestibular asymmetry which can be peripheral or can be central. This is for if you have a monophasic, which means an nystagmus in the same direction, just right beating or left beating. So what if we, after the head shaking, you find up beating or down beating in nystagmus? Central, yes. And what is the most common central vestibular disorder? What else? What is the most common central vestibular disorder? Migraine. Migraine is a neurological disease, and it's a central disease. So the most common central vestibular disorder is migraine, and you can see different central finding in migrainous patients. So if you see after head shaking vertical, up beating or down beating, that's a central of central origin. So what else? We have what's called biphasic after head shaking in nystagmus. So after the head shake, you have nystagmus right beating. Then after some time, just reverse its direction. Okay, so we called it biphasic after head shaking in nystagmus. And it can occur with central, with vestibular schwannoma. It can occur with peripheral disorders, with vestibular adaptation. And I will share with you one case. This is a young Egyptian colleague. He's really very smart, and he diagnosed very nice case and sent me the traces. His name is Mahmoud Shaban, and I'm really proud. He uses the Cyclops, and he's getting excellent records and really diagnosed many difficult cases. And this is from his traces. He sent me the video, but unfortunately, sending through the emails, the quality of the video not good. But if you look to the after head shaking, he found this biphasic nystagmus. So at beginning, it was, after the head shake, it was right beating. Then after a few seconds, it turned to become left beating nystagmus. So we ordered MRI, and the MRI shows left vestibular schwannoma. So if you have biphasic after head shaking in nystagmus, it will be worthy to get MRI imaging because it can occur with central disorders or with vestibular schwannoma. And this case was a case of vestibular schwannoma. And it was a left vestibular schwannoma. Hyperventilation test. How many of you do hyperventilation test? Perfect. Quite very good number. So how you do? Yes, Dr. Sandeep. How you do the hyperventilation test?
We ask the patient to hyperventilate for 1 minute.
Okay.
And then we put on the visor and ask him to focus at one point.
Perfect. That's very good. I found very nice article from Luigi Califano, one of our good Italian friends and one of the active members in our Facebook group. He wrote a very good article on hyperventilation test. I recommend it for you. So hyperventilation test is meant to reveal any lesion which causes atrial nerve demyelination, such as the schwannoma, vascular compression lobe, and multiple sclerosis. So the technique he recommended is to do in the sitting position, quick and deep respiratory cycles for 70 seconds. But yes, as Dr. Sandeep said, 1 minute is okay. We do 1 minute as well. So what is the physiology behind? Hyperventilation will cause washout of the carbon dioxide, leading to hypocapnia and respiratory alkalosis with hypocalcemia, and it affects the calcium channel ionic gates. And the hyperventilation increases the neural activities in the demyelinated nerve fibers, the end organs, and the cerebellum. Hyperventilation could change intracranial and perilymphatic pressure. So it can work either to increase the excitability in the demyelinated structures, either the nerve or the cerebellum, or it can work through changing the intracranial pressure. So sometimes the hyperventilation test will provoke an nystagmus originated from a dehiscent superior canal or from a perilymphatic fistula as well. So it's in Califano study, they found that it was positive in 21% of the vestibular patient, which really is a quite high percentage. And the appearance of nystagmus or a change in existing nystagmus, either it enhance or suppress. And for the presence of nystagmus, he put a very good definition that you have at least 5-degree nystagmus for 5 seconds within 1 minute after the hyperventilation. It's a very logic definition. Sometimes we accept the nystagmus to be of less than 5 degrees, especially if the patient is symptomatic. So most of the literature, they put like 4, 5.4, or the minimal slow phase velocity for nystagmus to be clinically significant. But honestly, in some clinical cases, we consider nystagmus of 3 degree or 4 degree to be clinically significant, especially if the patient is symptomatic. But it's as a start point, or it's a very reliable definition. So what positive hyperventilation test? It can occur with vestibular schwannoma, it can occur with vascular completion lobe, vestibular neuritis, multiple sclerosis, vestibular migraine, lymphatic fistula, and Chiari malformation or cerebellar degenerations. So let me to ask this. Hyperventilation test can help you to differentiate between psychogenic dizziness and organic dizziness. How's that? Yes.
It does help.
How?
So basically, these patients who are supposed to be suffering from, say, functional dizziness, now these patients do hyperventilate during those panic attacks. Now, if we can simulate that situation and we get a nystagmus, I think that helps.
Of an anxiety. And the part of the dizziness or psychogenic dizziness explained by presence of chronic hyperventilation. And you will find that those sometimes complain that when they exercise or go to the gym or walk for a distance, they start to feel dizzy. But the main thing that if there is hyperventilation-induced nystagmus, that's organic. And if there is subjective feeling of dizziness after the hyperventilation, but without nystagmus, that could be psychogenic. Okay? So this is how it's used. So for psychogenic cases, no nystagmus. If you find nystagmus, that means it's organic. But if the patient experiences, that is the same dizziness I feel, that is the same feeling I feel during the attacks, but without nystagmus, this may point to being of psychogenic origin. Good. Fistula test. What's your experience with fistula test? How common you find it positive in suspected cases of perilymphatic fistula? This side, any?
Pretty rare.
Just to share your experience.
So it's pretty rare, very rare.
Very rare, yes.
Fistula test positive. Fistula test positive.
Positive?
Fistula test positive,
Ah.
I have noticed in lateral semicircular canal fistulas due to cholesteatoma.
Yes.
And also...
But I mean how it's a sensitivity. Like you suspect a case of having perilymphatic fistula, then you
in superior semicircular canal fistula, only by that sound. It is sound-induced is positive. I've seen in 2 or 3 cases.
Okay, thank you. Actually, in our experience and the experience of other colleagues in different parts of the world, yes, Dr. Manoj.
I think one of the fistula test is that we have the bony labyrinth and we have the membranous labyrinth.
Yes.
If the bony labyrinth is breached, chances are that fistula test will not be positive. But if the membranous labyrinth has been breached by the disease, the fistula test has a higher chance of being positive.
Yeah, but clinically, overall, how sensitive you find the test?
That's what I'm saying. That clinically, most of the cases, it's only the bony labyrinth that gets breached, and therefore the sensitivity is low.
Okay.
In very few cases, is the membranous labyrinth breached. And there, the fistula test is not only positive, it's positive to the extent that the patient actually can cry out that stop doing this to me, something of that
I
sort.
fully agree with you. So overall, it's actually of low sensitivity. Part of, because of the pathology, like Dr. Manoj, he explained if there is affection of the bony labyrinth or just the membranous labyrinth. And part because it really needs a more pressure change to be induced. So usually tracheal pressure, don't exclude the diagnosis of perilymphatic fistula because when you do tracheal pressure, it didn't provoke nystagmus. Sometimes it need more stronger pressure. And one of my American colleagues, he's really, he asks the patient to do same like squatting position with excessive straining. And that's the only way they could provoke the nystagmus. So this is what's written in the box, like tracheal pressure, pneumatic otoscopy, and tympanometry. For tympanometry, the best way to do with tympanometry is to use a manual tympanometry. Some even computerized system now, they have the option to run it as manual. And you have to keep the pressure like for 20 seconds. So for it to work. Another one, he did this nice, I put for you the link for a nice video in the YouTube with really just little trigger pressure. They show very robust nystagmus. But in my experience, it's of low sensitivity, and it needs excessive pressure to be provoked. And it's not uncommon that perilymphatic fistula just presented with a position-induced nystagmus. This is some modification. He put the tympanometry tip in the tube with this air pump just to generate more pressure with a sealed end. So it's just the concept that negative fistula test, not enough to exclude the diagnosis of perilymphatic fistula or a third window syndrome because of the pathology, because of the efficiency of the pressure induced. If you want to improve the sensitivity, use more pressure. Valsalva test. There is two types of Valsalva test. It can be against the closed nostril, blowing the middle ears, or against a closed glottis, like straining, lifting a heavy object, which increases the intracranial pressure. And here a link for a video. So what conditions can you expect to have positive Valsalva test? Superior canal dehiscence, perilymphatic fistula, and Arnold-Chiari malformation. So let me to ask you, what would be the direction of nystagmus in superior canal dehiscence? With Valsalva test blowing the nose. Direction of nystagmus, I mean. Vertical, torsional, yes, it will be down beating with the Valsalva with closed nostril, and it can reverse if you do Valsalva with closed glottis. So in Arnold-Chiari malformation, what would be the direction of nystagmus? Down beating, always. Down beating in nystagmus. And, but it doesn't change. So always down beating in nystagmus and Arnold-Chiari malformation. Perilymphatic fistula, horizontal nystagmus. More common, it's more common to be from lateral canal origin. In my clinical experience, really, I didn't. It's more common to be horizontal. It could be definitely theoretically from posterior canal or from superior canal, but in clinically, most of the cases they are because of lateral canal perilymphatic fistula, which usually generates horizontal nystagmus. Okay, this is just to show the different mechanism of both the Valsalva or the pressure changes. It's almost work in the same way how sound can provoke or induce nystagmus. So for sound-induced nystagmus, what you do? If you clubbing, I use the clubbing. Any other ideas? You use a audiometer. What kind of stimulus and at which level you do?
250, 500, not above 1K. It has
250.
It has to be a low frequency, high amplitude sound.
Yeah, that makes it a mix of vibration and sound. Good.
I have a proven case, videos, everything. A doctor, superior semicircular canal resistance, 250 negative, 500 negative, 1000 a bit of response, 2 kilohertz. He gets huge nystagmus along with all.
That's interesting. That's interesting. Sound is different than vibration. So they didn't specify a specific frequency. For me, clinically, I use the clubbing. I bought the Barani box, noise box, but actually, even myself, I didn't see. But any kind of sound generator. Personally, I use the clubbing, yes. Vibration-induced nystagmus, or what's gaining popularity and called Dumas test, who's a French scientist, and one of our colleagues works with him. Dr. Solara supposed to come, but unfortunately, she has some difficulties. She couldn't come. So it uses a vibration. In the literature, you find that this vibrator have been used on the sternomastoid, then have been used in the mastoid, vertex, mastoid right and left. So the idea behind the vibration-induced nystagmus, it's again to reveal unilateral hypofunction. And he uses 60 or 100 hertz vibrator. He uses 60 hertz or 100 hertz frequency vibrator applied to the mastoid tip or the vertex or the sternocleidomastoid muscle. And it could be positive in superior canal dehiscence, where it induces torsional nystagmus. It could be positive in unilateral vestibular hypofunction. It's considered a high-frequency VOR test. It can induce vertical nystagmus in central disorders. So sometimes you read what's called vestibulogram, or what's called like vestibular testing in the frequency domain, because we have the caloric very low frequency test. We have the rotary chair, we have the video head impulse. Then we have this vibration-induced test, which is 60 hertz or 100 hertz frequency test. So you can test the vestibular system on different frequencies. Positional testing, I think that's important. You will find static, dynamic, positional, positioning. I hate these terms. I didn't find it of any clinical value. It just confuses the juniors, and it has no meaning for me. I always prefer to use Dix-Holbein test. It's a well-described test with a very definitive procedure. I use McClure-Bagnini test instead of supine roll or Hediau or why? Because for lateral canal BBV, the test is called supine roll. Actually, the movement, it's not in the roll plane. The roll plane is like this. So actually, it would be like the Hediau test. So because of this inaccurate name, I prefer the name of the two doctors or two scientists who invented the test, McClure and Bagnini. So McClure-Bagnini test, and it's written in this way in the Cyclops software. Other position can be used as straight head hanging or straight head extension test, side lying test, which is sometimes it's called the Simont diagnostic test, or it's some modification for the positional testing for anterior and posterior canal especially for those with back problems or neck problems. And the bow and lean test or showing test. So I like to name the positional testing with the names, such names, because it's very clearly described. You know what kind of position, you know. But when you say positioning, positional, and all this one, I found them confusing and not really of help. Definitely, positional testing may be the most important provocative test, and I will share with you some clinical hints. So the Dixwell bike test is the test of the posterior and the anterior canal, BBV, and the horizontal canal, BBV. How many of you sometimes see the nystagmus of horizontal canal, BBV in Dixwell bike? Good. So quite good number of the audience, they agree that the horizontal canal nystagmus appear in the Dixwell bike. And this is because of the orientation of the horizontal canal. Honestly, the horizontal canal orientation allows its nystagmus to be provoked with most of the positions. So usually most of the position, even sitting in the neutral position, it's sometimes, if you have a horizontal canal BBV, it can show what's called pseudo-spontaneous nystagmus. Leaning backward, bowing, head extension, Dixwell bike, head right, head left, all of these positions can stimulate the BBV of the horizontal canal. So that's why it's important to look for the direction of nystagmus. BBV should be diagnosed based on the direction of nystagmus, not the provoking maneuver. Benign paroxysmal positional vertigo should be diagnosed based on the direction of nystagmus rather than the provocative position. Because as you see that the horizontal canal can show up in most of the different positional tests. One of the interesting things about the Dixwell bike test, you will find in the literature what's called vertebral artery screening test. It's flow sensitivity and low specificity, but it's sometimes done. For me, Dixwell bike test is some sort also of vertebral artery screening test, because what you do extension and torsion. You do extension and torsion to the neck. So if you imagine if a patient he has vertebrobasal insufficiency or he has absent one of the vertebral arteries or atherosclerotic one with narrowing, sometimes it provokes the nystagmus and provokes the dizziness in this position. And in my experience, that most of those cases we labeled finally as a case of vertebrobasal insufficiency, the nystagmus is always horizontal, and we have explanation for this. And in like positional testing, they show a nystagmus which it does not change the direction. Because simply they found that either kinking of the vertebral arteries will decrease the blood flow, or stretching as well. So you don't know when you put a tested subject in the Dixwell bike test, it do kinking of the vertebral artery in one side and it do stretch of the vertebral artery in the other side. And either kinking or stretch, it can compromise the blood flow. Monitoring of nystagmus at the 3 steps is a good idea. That's put in Cyclops. If you go to for the Dixwell bike, so first sitting with the head 45, then the head supine, then sitting. So it's a good idea. Sometimes it's time consuming, but sometimes it shows a reversal phase. Sometimes it shows if you have like initial nystagmus before bringing the head down. So in Dixwell bike, this to summarize, if you have a right posterior canal BBV, so on the right side it's always upbeating torsional nystagmus. Sometimes you see in the other side an inhibitory component with a downbeating nystagmus, weak downbeating. But it's not a must, but sometimes you see. For left posterior canal, you will find on the left dorsal bike upbeating torsional and on the right weak downbeating. For the right anterior canal BBV, you will find anterior canal, like if you put the patient in the right dorsal bike. So which anterior canal you are testing? Correct? Yes. So it's a LARP and RALP. LARP and RALP. So always, like left anterior canal BBV will be more symptomatic in the right dorsal bike. And the right anterior canal BBV will be more symptomatic in the left dorsal bike. So just keep this in your mind. So just this is a summary for the vertical canal BBV finding in the dorsal bike test. Okay, apogeotropic or common cross BBV. Yesterday, Dr. Sandeep was talking in the dinner about that he's now seeing more cases of apogeotropic posterior canal. So simply, apogeotropic, geotropic, or posterior arm, anterior arm canalithiasis is a very clear concept with the lateral canal BBV. But the same principle can simply be applied on the posterior canal. So I do believe in its existence. It shows like sometimes like a downbeating nystagmus on the dorsal bike test with upbeating torsional nystagmus on setting. But I see also the common cross variant of BBV. They put here, it's in the apogeotropic, the otoconia, the blue one. Yeah, this one. But what happened? Sometimes you have the otoconia here in the common cross. Just think, if the otoconia in the common cross, what kind of nystagmus do you expect to see? Yes. Yeah, purely torsional. And simply why? Because posterior canal will cause upbeating torsional. Anterior canal, because it will do stimulation for both the anterior and the posterior canal. So you have simultaneous stimulation of the anterior and the posterior canal. So posterior canal, upbeating torsional. Anterior canal, downbeating torsional. So the up and the down will cancel each other. You have a dual component of torsional nystagmus. So that's why you have intense torsional nystagmus. We have a good number of recording of this very, very, very strong torsional nystagmus, which is suspect of the common cross. Yes. Same, but sometimes you need to do the maneuvers more brisk. Just more brisk maneuvers you do. We'll talk about this later.
Can I ask a question at this
Yes.
point, sir? So if it is in the common cross, the otoconia are in the common cross. Now, when you're doing a dorsal pike, isn't there a possibility of these otoconia falling into either the anterior canal or the posterior canal? And if they actually fall, because normally we wait for a while and we give it 1 minute in each position. So in the head hanging position, isn't there a possibility of the otoconia going into any one of the canals and producing a nystagmus?
There is possibility, but
Yeah,
anatomically, it's very hard to go to the anterior canal.
So to
and
produce
if it happened and went to the anterior canal, it will be easy to spontaneously come back by the effect of gravity.
Just a suggestion, sir. Just a suggestion came to my mind. Sometimes patients complain, well, when you take them back, there's no nystagmus, no problem, but when they get up, they have nystagmus. Yes. Can this be this variant?
Yes, especially for the apogeotropic posterior canal. Yes. It's called sitting up positional vertigo. It has a name. I think Turkish researcher who published. But this is published and reported, very well reported. So mainly they have the symptoms, not when lying down, but when simply, why? Because in the regular type, putting the patient dorsal bike will cause stimulation. And you know Ewald's second law, that is stimulation. Semicircular canals, they respond more for the stimulation than the inhibition. But if it's on the apogeotropic, because simply, if the otoconia is here, when you put the patient in the dixwall bike, there will be endolymph flow in this direction. So this will be inhibitory nystagmus, inhibitory stimulation, or inhibition. So always the semicircular canals, they are very optimistic. Physiologically, they respond to the stimulation much more than the inhibition. So this could be explanation. So to summarize, in dixwall bike test, just some tips. Common cross canal sizes can show with very strong torsional nystagmus. Apogeotropic posterior canal BBV provoke downbeating nystagmus in head-down position with upbeating reversal phase. A strong nystagmus usually followed by reversal phase in the same position. If you have sometimes those with very, very, very strong positional nystagmus from posterior canal, at the end of the upbeating torsional, just you have few beats of downbeating. As a rule, any kind of strong vestibular nystagmus, it's commonly followed by a few beats on the other direction. There is different explanation because of the strong deflection of the copula, then it comes back. There is a vestibular adaptation mechanism or something. So whatever, but don't get surprised that the nystagmus, after being very strong upbeating, it turned it for a few beats to be downbeating nystagmus. Strong nystagmus usually followed by reversal nystagmus on the other side of dixwall bike. It's very important. Your examination will not be complete until you examine the other side. Because really I got very interesting recording that you have very strong downbeating nystagmus from one side, but when you bring the patient to the other side, you have more stronger upbeating nystagmus. So it changed your interpretation of the test. So hold the final interpretation until you test the other side. Mixed canal BBV. We have, I think maybe we have the largest series, but we don't have time to publish a lot. But for the multiple canal, really, we have a huge number of cases. So we observed that simply, when you have a mixed canal BBV, what happened? It's always like if posterior canal and horizontal canal. So the posterior canal component will take over initially, upbeating, torsionally. Then after it subsides, the horizontal component. Theoretically, the nystagmus should be the sum, like oblique or something. But in reality, this is why I have constantly observed that no, what happened is the vertical component always takes over at beginning. Then after 30 or 40 seconds, the horizontal component become more same. It's important, we'll discuss this in the coming slides. When you do positional testing, you wait, don't rush. You wait and see what happened at the end of nystagmus or when the nystagmus ends. Duration of nystagmus is important parameter. So you have to be patient and wait until it ends. Horizontal canal nystagmus better seen in McClure-Bagnini test. Even if shown dixwall bike, go again and do the McClure-Bagnini test. We observed in some cases that it changes the direction. So you don't know it's a geotropic or apogeotropic type. So it's always for horizontal canals better to do the McClure-Bagnini test. Arnold Chiari malformation, it always present by persistent downbeating nystagmus, which does not reverse. Vertebrobasal insufficiency, in our experience, usual unidirectional horizontal nystagmus and dixwall bike test at both sides, either kink or stretch of vertebral arteries can provoke the symptoms and the nystagmus. McClure-Bagnini test, which test meant to examine or to look for horizontal canal BBV. So you have geotropic and apogeotropic. And here, let me to highlight, because that's confusing in the literature and sometimes in the textbook. So let me to ask you first. So what is geotropic and apogeotropic for you? Just to share your thoughts. We are here to share our thoughts. Yes.
Geotropic means beating towards the ground.
Okay. No, clinically, when you label this is a geotropic nystagmus or this is apogeotropic nystagmus. Because simply, if you have a spontaneous right beating nystagmus, when you put the head to the right, that's a geotropic nystagmus. So to make it clear, don't use geotropic, apogeotropic, except if you have a biphasic, bipositional nystagmus. So don't try to use this terminology at all, except if you have a horizontal canal BBV of geotropic or apogeotropic. Because I cannot, if I have unidirectional nystagmus, I cannot say geotropic or apogeotropic. It's one direction nystagmus. So when you put it in the same side, it's geotropic, and the opposite side is apogeotropic. So don't use this term. It's the only condition which you use the term geotropic or apogeotropic if you have a patient, when he turns the head to the right, he has a right beating nystagmus. When you turn the head to the left, he has left beating nystagmus, or the opposite. When you turn the head to the right, he has left beating. When you turn the head to the left, he has right beating. So it's a bidirectional and bipositional nystagmus. You get the point? Because to prove it's a geotropic or apogeotropic, you need those two positions. One position is not enough. So I have been through the literature and textbooks. Everything is sometimes confusing. So the only condition we can use geotropic or apogeotropic if you have a BBV or a similar condition to the horizontal canal BBV with an nystagmus which it changes its direction from bringing the head to the right after bringing the head to the left. Because one, if the nystagmus is towards the ground in one position, not enough to say geotropic. At least you have that nystagmus keeps looking to the ground in head right and head left. Otherwise, don't use, it will be confusing. Yes, in McClure-Bagnini test or positional testing, sometimes you see a unidirectional nystagmus, like left beating or right beating. It doesn't reverse. Geotropic or apogeotropic, the nystagmus should be reversing its direction from left to the right. But sometimes you see a nystagmus only in one side, which is not reversing. We have seen this like in perilymphatic fistula, in vascular compression lobe, vertebrobasal insufficiency migraine, central cases, and vestibular schwannoma. And let me to ask you any kind of explanation why, like if you have a vascular lobe, why or you have a vestibular schwannoma, why it only shows nystagmus in a certain position? Simply, you have explanation?
Yeah, because of compression of the vestibular nerve. In certain positions, there is kinking of the nerve because of tumor or any pathology, and that reduces the conduction and simulates acute unilateral vestibulopathy for transiently during that position.
It's good, but the main factor is the gravity orientation. Gravity orientation. Because if you have a vascular lobe or you have a mass, its weight, pressuring on the nerve or the blood supply, can change the degree of compromise by changing the gravity orientation. So that's why in certain positions, the gravity will let these conditions, the vascular lobe or the mass, do more compression in this position. So it's a matter of gravity orientation. Geotropic, apogeotropic only for bidirectional, bipositional, reversible nystagmus. Latent spontaneous nystagmus can show on positional test. Take care of this direction. We mentioned this before. If you want to enhance a weak nystagmus, use Alexander law. So yes, another tip, horizontal canal BBV versus central nystagmus. Geotropic type, it's more commonly to be of peripheral origin, but there is cases where it shows to be of central origin. Apogeotropic type, there is more opportunity or more chance to be of central origin than the geotropic type. So what kind of parameters you can use to know it's either peripheral or central? First, the duration of nystagmus. We read in the box transient, persistent, prolonged. So what's your cutoff point for the duration of nystagmus? 2 minutes. Else? 3 minutes. Okay, 4 minutes. I will use Professor Asperal Libonati, a great Italian professor. Really, he put 4 minutes as a cutoff point for nystagmus. So if the nystagmus lasts more than 4 minutes, it's most likely not of BBV origin. You have to think about other causes. So I use personally the 4 minutes. Yes, you have to be patient, and I put the patient in the position, and yes, we record 4 minutes. So if the nystagmus lasts more than 4 minutes, it's most likely to be of BBV origin. You think about other differential diagnosis. It could be because of migraine, because of light copula, heavy copula, or other central causes. But personally, I use the 4 minutes. It's more conservative, 4 minutes duration. Crescendo, decrescendo. So what's crescendo, decrescendo? Crescendo, decrescendo, it's long time described the characters of BBV nystagmus. So it very fast reach its peak, very fast, then gradually calm down. So very high slope in increasing, then slowly decreasing. This is very clear in the posterior canal, less evident in the horizontal canal BBV, but really it's a good sign. So if you have a nystagmus which it's a very fast build its velocity, then gradually decrease, that goes with the BBV origin. But if you have a nystagmus, since the beginning it has the same intensity, same velocity, same, which is not changing, that's most likely not a BBV. Okay? So the duration and the crescendo, decrescendo character, and the most important, they respond to repositioning maneuvers. So finally, if you do the maneuver 2-3 times without a response, whatever you see, just ask for MRI or search for other causes. Heat hanging test, it might better show downbeating nystagmus. It can differentiate bilateral from unilateral posterior canal BBV because theoretically, if you put in the head hanging, if you have a patient with bilateral posterior canal BBV, so the torsional component from each side will cancel each other, and you have a purely vertical upbeating component with the head is in the central head hanging position. Be cautious with the recent stroke vertebrobasilar insufficiency, because the worst is to do head extension. This is maybe the worst position which compromises the vertebrobasilar flow. Head hanging test, it can be another way to do the bow and lean test. Bow and lean test, it's very nice. Sometimes, like last week, I have a patient on a wheelchair, very hard to bring in the bed. So we tested for a horizontal canal, we tested with the bow and lean test. You can do while the patient on a wheelchair or while the patient on sitting. So you bring the head 30 degrees down, then wait and see, then in the neutral position, and then head extension, and see if the nystagmus, it changes its direction. There is important point. When you examine, you do a positional testing, especially for the horizontal canal, you have to wait in the middle. Why? What's the ideal way to do? To either bring the head to the right then you bring the head to the left, or bring the head to the right, then wait in the center, then go to the left.
It's better to wait in the neutral
Good,
because the
perfect.
particles will
Why?
settle down, because it's a positioning nystagmus. Because in, for example, in lateral canal, if patient is sitting and then lies down, that is in the neutral position, the nystagmus is different. And suppose you take the patient from left lateral, suppose to the neutral position, in the same patient you can get different direction of nystagmus. So it's a positioning nystagmus. That's why the direction will change as per the previous position. The previous position from which the patient is attaining neutral position is important. If a patient is attaining from sitting, it might be different, and from lateral it might be different. So it is very important to let the particles settle down and then go for the another position.
Thank you, Dr. Vishal, but it's mainly because of the velocity storage mechanism. You read about the storage velocity mechanism, that it is stronger for the horizontal canal. It prolongs the vestibular nystagmus. So if you didn't wait in the center, you will get the same direction of nystagmus on the other way. So it's ideally you should wait at least 30 seconds to wait until the velocity storage mechanisms stop working, and you can get the reversal phase. So,
sir,
yes.
There seems to be a different reason also. Suppose it is left horizontal canal, canalolithiasis, we did the move towards left side.
Okay.
What the particles which were lying in the middle of the canal now have moved ampulopetally. They will induce a nystagmus which will be excitatory nystagmus. We notice the intensity, frequency, etc. I'm talking of without VNG, let it be without VNG. Or even with VNG. And now, if we immediately, without stopping in the center, turn the head towards the opposite side, now the particles will be moving 180 degree away from that. Will be, what I want to say is it will be the stronger flow of the endolymph, which will create a more stronger nystagmus on the other side, and then it will become confusing for us to decide the side of the involved canal.
That's a good point as well, thank you. So as a rule, you wait in the middle. Well, optokinetic stimulation. For those doing regular VNG testing, what is the most significant value of doing optokinetic test?
There are two things. One is discomfort on optokinetic stimulation is very common in vestibular migraine. And second, I find is in acute unilateral vestibulopathy, the directional preponderance on one side indicates, for example, the stimulus is moving from left to right, there will be left beating nystagmus. And if the stimulus is moving from right to left, there is right beating. So if a patient has gain more on one side, more likely I expect that he's going to have a spontaneous nystagmus in that direction, and he's going to have unilateral vestibulopathy on the other side, that is slow phase, towards the slow phase.
Thank you, Dr. Vishal. I fully agree with you. So we'll go through a few tips about the optokinetic. There is two ways to do the optokinetic test, either look or stare. So look, you ask the patient to follow the stimuli or the lines. He can count or follow the stimuli. So actually, will test the pursuit system. So you will have these responses will be a combination of smooth pursuit and saccade, smooth pursuit and saccade. Stare, this is to test the optokinetic reflex, which uses the peripheral retina, and the patient shouldn't just be staring without doing anything. This is to test the optokinetic reflex. So be careful. Sometimes it's hard to separate, but the ideal optokinetic test is to do the staring. Don't let the patient to count and not to follow, just stare in the center. It's a reflex. The patient shouldn't do any intentional or voluntary things. It's just a reflex, and it's a subconscious reflex. It should happen subconsciously. So this is the first point. Second, effective velocity. The test sensitivity improves if we go. So like I don't use the 10-degree test, it's of low sensitivity. I use the 20, and I'm asking to add more velocity options, because they found that if you increase the velocity, the test become more sensitive. Reversed pattern. If you have a patient with congenital nystagmus, so his optokinetic responses will be on the opposite direction from the normal or from the expected. This rhythmic traces. If you find too much irregularity, that comes sometimes with the central lesion. Same like saccadic pursuits or this one, it can show also on the optokinetic. You have a very dysrhythmic and irregular responses. Optokinetic response can be affected by nystagmus, abnormalities in the saccade and smooth pursuit. So what is the most constant and significant finding? In our experience, I agree with Vishal, that is the discomfort and the visual motion sensitivity which occurs with migrainous patient. This is maybe the most constant finding I've seen. Vestibular migraine or migrainous vertigo is the second most common cause of vertigo in our database. So most of those migrainous really, they got very upset, they got annoyed, they feel dizzy, they feel discomfort, they complain. This is, we consider it some evidence for visual motion sensitivity, which one of the characteristics of the vestibular migraine. So now I believe, I consider it a sign which it helps in the diagnosis. Yes, in optokinetic gain asymmetry is important, and yes, in any cases with unilateral vestibular loss of central or peripheral origin, it can give you a gain asymmetry. So now we'll go for the caloric testing. I'm not a big fan personally with the caloric test, but still it's important. How did we know that caloric test is very low frequency VR stimulus? Just historical. It's always written in the box that it's 0.3 hertz frequency. You know from where that number came? Simply, it came from the duration of the caloric response. So they found that the maximum duration of caloric response is 180 seconds, 3 minutes. So they speculated that it's like a sinusoidal function, with 1 half cycle is 180 seconds. So to calculate the frequency, they divided 1 by the 180 seconds. So that's why from came the number, why they know it's a very low frequency vestibular stimulus. Water versus air, definitely air is less efficient stimulus, and water is more reliable test in caloric stimulation. Mini ice caloric test, I love that test. I can see it is more easily to control the stimulus, takes shorter time, more reliable test results. That's my personal experience. Mental tasking is mandatory. You know what happens if you do a caloric testing to a comatose patient? What kind of response you expect? You did caloric stimulation in a comatose patient. You will get nystagmus? Yes, Vishal.
It depends on what type of coma that patient is suffering. If the patient is suffering from brainstem coma,
not a brainstem. Brainstem is intact.
Yeah, only slow phase will be seen. The fast component will be absent.
How it looks like?
The slow component, if it's stimulated, suppose
how it looks like? There is nystagmus or no?
There is no nystagmus.
Yes, just a deviation of the eye, drift of the eye, toward this stimulation side. So just you have a drifting of the eyes, no fast phase component, which is the saccades. Saccades needs the cortex, conscious cortex, to be generated. So in comatose patient, only you get a drifting of the eyes with the caloric stimulation. So during clinical testing, if you want nystagmus, you have to keep the mental alerting. It's very important. Do a mental task, count reversibly 197, 94, or just another mental task. But if the patient not more concentrating, drowsy, or not alert enough, you get a very weak response, or very weak nystagmus. Prone caloric test. When you use a prone caloric test, simply, if you do ice caloric test, if you have a spontaneous nystagmus and you want to know if there is some response from that side or no, you didn't get a response with the mini ice caloric test, it's simply bring the patient in the prone position. We tested the caloric in the supine position, so that's why the cold stimulus will make inhibition. But if you put the patient in the prone position, it will become excitatory position. And as we know, semicircular canals always respond more to the excitation rather than the inhibition. So it is some sort, we use it with the same. You do mini ice caloric test in the supines, and you get no response, just turn the patient on his face, on the prone position, and they see. If you get a response, that means there's still some residual function in this side. Very rarely we do, but we did few cases. So the limitation of caloric test, it's not a direct vestibular test. It's easily affected by the heat transmission mechanisms. So if you have a very well aerated mastoid, it compromises the heat flow. Do better if it's sclerotic mastoid. So it's actually not a pure vestibular testing. That's a big major limitation. Can be affected by the technique of irrigation, efficiency of irrigation, efficiency of temperature control, mental alertness of the tested subject. So it has some limitations. Sometimes it induces vomiting and nausea, and it's not very well tolerated. So those are the limitations of caloric testing. One more point, that is regarding the caloric test in Meniere's disease, because that's again clinical popularity, the dissociation between the results of caloric testing and the video head impulse test, especially in Meniere's disease. And finally, the most working explanation for this dissociation is with the endolymphatic hydrops, the dilated lateral canal become not suitable to do the convection currents. So the heat transmission mechanism got affected by the dilatation. They did a computer models and some studies, they found that if the canal is good dilated, it will not generate the convection current in the regular way. That's why caloric stimulation is not enough. So it's not a matter of loss of function, it's rather mechanical changes and heat transmission changes because of the endolymphatic dilatation, or because of the dilatation of the lateral semicircular canals. That's why in video head impulse you get the function normal, but with caloric test you get a weaker response or abnormal response. So this could be used as a pathognomonic sign for Meniere's disease. You have a normal video head impulse, then you have a caloric weakness on the affected ear. So the caloric weakness in this condition is mainly because of the heat transmission mechanism changes. So last slide about the magnetic stimulation. They use the 7 Tesla MRI, work done by the Johns Hopkins group. It's used to test a kind of vestibular asymmetry, like the other provocative test, the head shaking, the vibration induced. This is the last question in this. I want you to think, it always gives a horizontal nystagmus. And also cases of vertebrobasal insufficiency. In most of the cases, they give horizontal nystagmus. Also, most of the cases of Meniere's disease, they give horizontal nystagmus. So do you have explanation for this?
Yeah.
Yes.
If all the canals are stimulated on one side, the resultant effect of the effect on the extraocular movement is horizontal, because the other component gets cancelled with each other.
Excellent, Dr. Vishal. Yes, that's correct. Just simply any condition which causes simultaneous stimulation of the three canals or simultaneous inhibition of the three semicircular canals will generate a net sum of horizontal nystagmus. Because if you stimulate the vertical canal and the anterior canal simultaneously, the vertical components will cancel each other, but remain the torsional components. So any kind of condition which causes either stimulation of the simultaneous stimulation of the three canals or simultaneous inhibition like the magnetic stimulation or simultaneous inhibition of the three semicircular canals, you got a horizontal rotatory nystagmus, horizontal component with the torsional component. Thank you.